Hey guys, this is Josiah. Just wanted to do a quick video on the most common types of birth control used in women. There's two main types. There's more than this, but these are the two main ones. We have the IUDs, so intrauterine devices. So if you look at the cursor, they're actually placed into the endometrium in the uterus past the cervix. And there's two forms. We have copper, and we have basically a progesterone or progestin impregnated implant. And then we got the other common, which is oral birth control. And this can be given either in cyclical fashion or continuously, so you don't have like a shedding of menstruation. So I wanted to talk real quick about how the cycle actually works before we get into talking a little bit more about how the IUD versus the progesterone works, or the copper versus the progesterone, or the estrogen progesterone combination pill that's very common also. So basically the menstrual cycle is split into two phases. We have the follicular phase and we have the luteal phase. And this is based on a 28-day cycle, as you can see on the bottom here. This here is menses. And this is the regrowth of that uterine lining where the implantation, the egg and the sperm will meet to start the growth of a baby, basically. In the follicle phase, the follicular phase is called follicle because the ovary is developing an egg. Here we have around day 14, we have ovulation of that egg. And then once it's ovulated, we have what's called the corpus luteum here that secretes progesterone. So you can kind of see how that progesterone is secreted. The reason that progesterone is needed is to keep this lining from shedding and having menstruation, which the baby would go with it. So that progesterone keeps the lining in that full thickness, so plenty of blood flow for the baby. Now, the hormone that grows in the ovary, this baby, is actually follicle stimulating hormone, and we can kind of see that. Let me make the cursor a little small right here. We can see how that through the 28-day cycle, this blue line is essentially peaking around ovulation. And so it increases and ramps up to get this baby going and then peaks at the ovulation. That's the development of the follicle, or the oocyte, the egg. In order to have the rupture of that egg out of that follicle, we need a peak of a second hormone that comes from the brain called luteinizing hormone. And that luteinizing peak is what a lot of people are using urine tests to check for when they're trying to get pregnant, to find that peak so they know they're right around essentially ovulation time. And that luteinized hormone causes the egg literally to fall out of the ovary, go down the fallopian tubes, down into this uterine lining where a sperm can come up and meet to start conception, essentially. Now, the estrogen is also stimulated from that follicle stimulating hormone. And that estrogen that is secreted actually allows the start and the buildup of this uterine lining. It doesn't keep it around permanently in a normal menstruation cycle. That's the job of the progesterone, because the estrogen will fall off. You can see this purple line, allowing us to come full circle back into menses. So essentially, the first 14 days, the predominant hormones are estrogen. The second 14 days, day 14 to 28, is progesterone. Now, if that luteal phase, if that egg isn't implanted, the progesterone will drop off and you will go into menstruation, which is usually typically day 1 through 6, and the whole process starts over again. So those are the main things. Now, the follicle stimulating hormone, the luteinizing hormone, come from the brain, and there's this feedback between the ovary and the brain to control that cycle. I just wanted to do a quick overview so we can kind of talk about the hormones, because the IUD, progesterone, we're giving progesterone, versus the continuous pill or the cyclical pill, which has a combination of estrogen and progesterone in it. So let me clear this out. So let's cover the IUD first. There's two forms. We have the copper, which you can see there, and then we have the progesterone, essentially, progestin that's used. Now, this is placed by somebody who has training in it, and it actually goes through the vagina, through the cervix, and implants in the uterine cavity, kind of against the cervix there. So there's two forms. The common form that's used quite a bit these days is copper. Both are almost 100% effective, but the difference is the time. You can see it's 10 years that you can leave the copper in versus either 3 or 5 years, depending on the strength of the progesterone, which the 13.5 versus 19.5 and 52 milligram. There is reasons not to use the high dose one. It's usually used, the progesterone form, the 52 milligram, if you have excessive bleeding or very painful menstruation, because you're trying to shut that down a little bit. There's only 2 contraindications to not use the copper. Technically, there is a whole list, but the 2 main ones are if you have Wilson's disease, which is essentially a genetic thing where you can't get rid of copper, or if you've had a sensitivity to some type of copper, you wouldn't want that device in your body. How the copper actually works is It's a reactive oxygen species, essentially, which causes cell injury to the endometrium layer here in the uterus, where the egg actually floats down into implant, and then the sperm coming up, it actually is toxic to the sperm. So essentially, you're just preventing the cells from functioning properly and preventing that sperm from entering the ova there. The IUD that's copper, you will have a fairly normal menstruation, and that's because it's non-hormonal. It's not going to affect those hormones that we talked about. The progesterone, we don't want to use this if you have any breast cancer, uterine cancer, any cancer that's going to be driven by hormones. And personally, I probably wouldn't be messing with hormones if I had any type of cancer, or any type of liver disease, obviously, because hormones are controlled by the liver, and we don't want to increase the risk of coagulation issues because the liver makes all that. But the progesterone form, it basically thickens the uterine lining, like we had talked about in the slide before. It actually grows the uterine lining, keeps it, or not grows, but it keeps it thick. And if it's thick, it's or prevents it from thickening to bring all that blood flow in there to keep a viable egg from to grow, essentially. The other thing it does is that cervical opening that the sperm has to make its way through, it thickens that mucus lining, essentially, that mucus that's secreted, and the sperm have to swim up there, and it can't get through that barrier. It's so thick, basically stops it. Now the problem, there's a couple things that can happen with the hormones. If we have lots of progesterone, we're going to shut down the normal menstruation cycle. We can have less bleeding, lighter periods, or we stop it completely. But the side effect is, like all hormones, it can drive cancers if we're susceptible to that. Although there's a lot of controversy in that currently. Go to the next slide here. So I want to talk a little bit about the pill. The pill is a combination. It has the estrogen in it, and it has the progesterone. And so you're essentially, by taking these at doses that exceed your own body's natural production, you're going to stop these two brain hormones, the luteinizing hormone and the follicle stimulating, from actually working. So that's kind of how that does. The main way that this prevents pregnancy is it basically suppresses follicle stimulating hormone. And so if we don't produce follicle stimulating hormone, we don't produce an ovum, an egg, that we can even ovulate to get into the uterine lining. So we're basically shutting down the egg production from that oocyte growing to maturity enough to ovulate. And if you don't ovulate, you don't get pregnant. So there's a couple ways to give this. There's three main ways. There's the monthly withdrawal. In a different slide, let me go back, kind of showed the pill in a 28-day cycle. So we have 7 days of hormone, 7 days of hormone, and we have 7 more days of hormone, and then we have this. And this is red because it probably has iron in it. There's no hormone. So essentially we're taking iron. When we come off the 3 weeks, we're going to have a withdrawal because we've got that a little bit thicker endometrium that essentially is going to come off these high doses of estrogen and progesterone, and it's going to shed a little bit. It is not a true menstruation. It's essentially a fake menstruation. It doesn't work exactly the same way, essentially. So if we go back to the combo here, so essentially we don't have to give that 7-day iron pill. So what some people will do is take the 21 days of the 28 and they'll back to back that, and then take the 7 days. So you're taking 84 days straight of the hormone and then a 7-day withdrawal, which essentially is giving you like a quarterly bleed, or every 4 months a bleed that can shed some of that. Some people don't take that 7-day interruption and they'll go continuously for 365 days. Now this comes in multiple different forms of estrogen dosing. 50 micrograms is considered kind of the high today, although 20 or 25 is more commonly used to start. Obviously, you're messing with hormones. Stronger isn't always better. There's more increased side effects the stronger you go. So if you can get by at a 20 to 25 microgram dose, that's better. You can always go up in dose incrementally if you're breakthrough bleeding when you're not wanting to bleed. So that some of the common side effects I've seen with new users is nausea and ab pain. There's always a risk of DVT when you're messing with doses of estrogen that is so high, and that liver involvement with the coagulation. And then there's always an increased risk using estrogens and progesterones with smokers, as there's increased risk of DVT. Obviously, you don't want to mess with hormones if you have cancer. That's a no-go thing. The other problem is if you miss 2 pills, you essentially need to go, if it's early in the pill pack, because you're having withdrawals, you need to go at least 7 to 14 days of condoms or some other form of protection to prevent pregnancy to get back on that next cycle. If you miss 2 days and you're kind of at the tail end of the pill, definitely 7 days would be fine until you can get that next pill pack started. And that's the usual recommendations for that. If you have any questions, let me know. Feel free to reach out to me. Thank you.